Please start.
Okay. Good morning, everyone. Please, I'm sincerely sorry for the hiccups. My laptop was not responding. I'm sincerely sorry. Today we shall be looking at type 2 diabetes, and my name is Abidemi Owa. Okay, sir. So by way of introduction, type 1 diabetes mellitus remains the commonest form of diabetes in children worldwide. But the incidence of type 2 diabetes mellitus is rising in parallel with the epidemic of pediatric overweight and obesity. That means there is a newer trend such that the type 2 diabetes mellitus too is rising with the increment in obesity and overweight in children. And it's often seen in the second decade of life and rarely before puberty. So it coincides with the peak of physiological pubertal resistance, pubertal insulin resistance. And most children have a family history of diabetes, either in the first or second degree relative. The epidemiology is mostly seen in second decade of life. The highest prevalence has been documented to be found in African American, Native American Indian, the Hispanic and Southeast Asian groups, but there are wide variations depending on the age, the ethnicity, and geography. And it's important to note that there is a discord in what is found in the developed nations and what is seen in the developing nation, such that type 2 diabetes mellitus is seen in the lower socioeconomic status in the developed nations, while in the developing nation is seen in the upper socio-economic status. Means in developing nations like ours, like maybe in India, in Nigeria, Africa, type 2 diabetes mellitus is seen more in those ones that are the affluent. Incidence is put at 0 to 330 per 100,000 person years, while the prevalence of type 2 mellitus is between 0 to 5,300 per 100,000 children and adolescents. By way of definition, diabetes mellitus is a group of metabolic disorders which is characterized by chronic hyperglycemia due to defects in insulin secretion or insulin action or both. But it's important to note that for type 2 diabetes mellitus, two things come to mind readily. The first thing that happens is it's often preceded by insulin resistance and then apoptosis of beta cells. A look at the pathophysiology of type 2 diabetes mellitus shows there is a progressive imbalance in the glucose homeostasis, and is often understood that insulin resistance, like I said earlier, is the first feature to develop. Then clinical diabetes requires a second hit of beta insulin insufficiency. And the relationship between the two has been described by a hyperbolic function and can be quantified by the glucose disposition index, which can be calculated by multiplying the insulin sensitivity and beta cell function. The hyperbolic function is shown such that in individuals who are highly insulin sensitive, a low insulin secretion will be seen. While if the sensitivity is very low, higher concentration, higher secretion of insulin is seen, such that it varies between insulin sensitive individuals and insulin resistant individuals. In insulin sensitive individuals, the sensitivity is high and the secretion is low. While in insulin resistant individuals, the insulin secretion is high, while the sensitivity is low. So some genetic factors have been adduced to type 2 diabetes mellitus. It's highly heritable and evidenced by concordant rates, of which about 50 to 92% in monozygotic, compared to 34 to 42% in dizygotic twins. And it's documented that if one parent has diabetes mellitus, the risk increases by 30 to 40%. But if both parents have diabetic mellitus, the risk increases by 70%. And a common variant has been shown to contribute to about 10% risk of type 2 diabetes and heritability. Some of the genetic genes predisposing to type 2 diabetes mellitus have been found. Those that has to do with insulin secretion, the CDKAL1, CDKN2A, CDKN2B, once they are affected, they result in reduced beta cell mass and decreased insulin secretion. While if there's an affectation of MTNR1B, TCF7L2, KCNJ11, those leads to beta cell dysfunction. The insulin may be there, but the function is not optimal. While if there's an affectation of the FTO gene, there is insulin resistance, and it's often seen in obesity associated with insulin resistance. An affectation of the IRS1, PPARG is seen in individuals with insulin resistance with obesity. So environmental and epigenetic factors have been seen in type 2 diabetes mellitus. The worldwide rise in type 2 diabetes mellitus prevalence underlines the importance of environmental factors, since changes in gene are unlikely to cause such rapid changes. So increase in type 2 diabetes mellitus causes cases which parallels the obesity epidemic, highlights that rapid environmental changes are leading to increased risk of metabolic diseases. It leads us to there's an hypothesis which is called the fetal origin of adult diseases, which is proposed by Baker. Some call it Baker's hypothesis. And the observation is that during a critical period of fetal undernutrition, it may lead to permanent changes in the endocrine metabolic unit, while favorable in the short time, and may lead to an increased risk of adult metabolic disease when exposed to a state of postnatal nutrient excess. The fetal programming, as proposed in the Baker's hypothesis, leads to insulin resistance because there is an overactivation of the hypothalamic pituitary adrenal axis with a change of its set point, leading to increased cortisol secretions. Means during that state of not having much, there is overstimulation of the hypothalamic pituitary axis, which leads to hypercortisolemia. And also, the pancreatic organogenesis is also affected, which leads to reduced beta cell mass. So in essence, there is, in the state of not having much, the baby may suffer intrauterine growth retardation, which will lead to perinatal nutrient restriction. And there is increased fetal glucocorticoid exposure, which will have effect on the liver, leading to decreased glucose uptake. There is reduced gluconeogenesis, and the effect on the pancreas, there is increased beta cell mass and secretory capacity, while the effect on the skeletal muscle, there is increased lipid oxidation with reduced insulin sensitivity. While on the adipocyte, there is decreased insulin inhibition of lipolysis. If all these work together, It leads to decreased pancreatic and functional capacity with glucose intolerance leading to insulin resistance. And consequently, the child may develop type 2 diabetes later in life. So the criteria for diagnosis of diabetes, the first is classic symptoms of diabetes or hyperglycemic crisis with plasma concentration greater than 11.1 millimole per liter, or fasting glucose greater than 7.0 millimole per liter, or 2-hour post-load glucose greater than 11.1 millimole per liter, or HbA1c greater than 6.5%. And the American Diabetic Association criteria for testing type 2 diabetes mellitus or pre-diabetes in asymptomatic children. We should screen every child that may present with overweight. That means the BMI, if it's greater than 85th centile for age and sex, the weight for height greater than 85th centile or weight greater than 120% of ideal for height. Any child that has such plus one or more of the following to be highlighted stands risk of having diabetes. If the child is overweight and there is maternal history of diabetes or history of gestational diabetes during the child's gestation, such child should be screened. Or if there is overweight with family history of type 2 diabetes in the first or second degree relative, or there is a race ethnicity, if the person is from the Native American or is from African American or a Latino, or is from Asian American or from Pacific Islander or from Southeast Asian, such individuals should be screened. And there are signs of insulin resistance or conditions associated with insulin resistance, such as acanthosis nigricans, which occur from the hyperinsulinism leading to hyperkeratosis. Such individuals should be screened for diabetes. If there is hypertension, or there is dyslipidemia, or there is polycystic ovarian syndrome, or the child is small for gestational age. Because small for gestational, like I said earlier, from the fetal hypothesis, is a prelude to developing hypertension and diabetes mellitus later in life. So all this, once we have a child with overweight, plus one or more of the following: maternal history, family history, race or ethnicity, or signs, should be screened for type 2 diabetes. The presenting feature: obesity is key in feature of is a key feature of type 2 diabetes mellitus. Most patients present in puberty when there is physiologic insulin resistance and it's at its peak. And it's often there is family history in the first degree relative, which is around 74 to 100%. And the presentation of type 2 diabetes mellitus is generally more insidious compared to what we see in type 1. And in a third of patients, the diagnosis is made on screening of asymptomatic individuals. That means they are not as sick as those babies that will get type 1 diabetes in them. Severe presentations are not unknown, and up to 25% of children with type 2 diabetes mellitus may present with a DKA. Ketosis and diabetic ketoacidosis have been demonstrated, but more commonly in children from ethnic and minority groups. The first presentation in type 2 diabetes mellitus may be a hyperglycemic and hyperosmolar state, and it has been described. Others may present with vaginal candidiasis, which is a common feature. Another may present with acanthosis nigricans, as in a majority of patients. Other comorbidities, such as hypertension, polycystic ovarian syndrome, fatty liver, and sleep apnea, can present at diagnosis, in contrast to type 1 diabetes mellitus, where complications occur only years into diagnosis. So a quick look at how to differentiate type 1 diabetes mellitus from type 2 diabetes mellitus. The increasing incidence in children with type 2 diabetes mellitus and the current high prevalence of overweight and obesity present clinicians with a diagnostic challenge when evaluating a patient with newer onset diabetes mellitus. If the child is overweight or is obese, it's leaning more towards type 2 diabetes than type 1 diabetes. But there are some features that may be difficult because they may overlap in presentation, and some patients may have clinical and biochemical features of both types. Ketonuria is unusual in adult patients with type 2 diabetes mellitus, but many adolescents with type 2 diabetes mellitus have ketonuria or even DKA at presentation. If the insulin requirements decreased after several weeks of treatment of type 2 diabetes mellitus, it may resemble the remission or honeymoon period of type 1 diabetes mellitus. And if we measure the pancreatic autoantibodies at the time of diagnosis, it will go a longer way in distinguishing type 1 from type 2 in obese patients, such that the autoantibodies are seen in type 1 diabetes mellitus and are rarely seen in type 2 diabetes mellitus. If we assay for plasma C-peptide concentrations, which is a sign or which gives an index of the endogenous secretion of insulin, it may overlap between the subtypes of diabetes in the acute phase and may not be helpful in classification. But persistent elevation of the C-peptide, say 12 to 24 months after diagnosis, may be unusual in type 1 diabetes mellitus, because like I said during the presentation for type 1 diabetes mellitus, that as the disease progresses, the secretion of the insulin and C-peptide decreases until a level that is no longer, that it will get to a very low level. But if it's persistent, say after 12 to 24 months of the diagnosis of type 2 of the diabetes, it's more likely to be type 2 diabetes mellitus. Fasting insulin-like growth factor binding protein 1, whose secretion is actively inhibited by insulin, is a marker of insulinization with a very low IGF BP1 concentration, being suggestive of type 2 diabetes mellitus. So identification of autoantibodies such as GADA, IHA2A, insulin antibody, this zinc T8, IAA is highly suggestive of diagnosis of type 1 diabetes mellitus. And in a patient with normal insulin sensitivity who has a normal waist-hip ratio, the differential diagnosis includes MODY, diabetes secondary to other conditions such as cystic fibrosis and other rare forms of diabetes. On the other hand, an increased waist-hip ratio with insulin sensitivity is suggestive of type 2 diabetes mellitus. So the management and therapy, the key thing here is lifestyle and activity. For the lifestyle intervention is a cornerstone of care for type 2 diabetes mellitus. And current guidelines recommend at least 60 minutes a day of either moderate to vigorous exercise and limiting non-school related screen time to less than 2 hours per day. So regular physical activity in youth with type 2 diabetes mellitus has been associated with improved HbA1c. It will help to lower the basal body mass index and also improves the cardiovascular dynamics in such person. So key to lifestyle, key to management in type 2 diabetes mellitus is lifestyle and activity. Then after that is the diet, what the person consumes. So we advocate for a reduction in calorie consumption to induce gradual weight loss. One will have to eliminate sugar sweetened beverages. There will be a need for increments in the intake of fruit and vegetables. There should be reduction in consumption of processed foods and simple carbohydrates. There will be increase in low glycemic index foods and reduction in portion sizes. If one can do this, at least this will help to facilitate weight reduction. And if the weight reduction increases, there is some improvements in insulin sensitivity. So the medical therapy, insulin and metformin are recommended as most youths with type 2 diabetes mellitus are unable to attain targets with lifestyle changes alone. One, insulin is recommended at diagnosis if there is ketosis and if the random blood sugar is greater than 14 millimole per liter or the HbA1c is greater than 9%. While insulin is required if lifestyle changes and metformin is not able to attain glycemic control. So one may use long-acting glycine or determine at 0.25 to 0.5 units per kg per day, or NPH once daily dose. While metformin, which is a biguanide, which helps to reduce hepatic glucose production with lesser effects on reduction of intestinal glucose absorption and improvement in glucose uptake and use. It does not improve insulin sensitivity, but it is the first-line oral hypoglycemic in youth with type 2 diabetes mellitus. It helps improving glycemia without promoting weight gain or hypoglycemia. But it's important to note that it has a good safety profile, but carries a real risk of lactic acidosis. And so one has to be very careful, as is not recommended in people with renal impairment, those with cardiac and respiratory insufficiency, or individuals with gastrointestinal illness or receiving radiographic contrast. Side effects of metformin include mild diarrhea, may have nausea, they may present with dyspepsia, flatulence, abdominal pain, which reduces as the time goes by. To minimize the side effects, we often start as a dose of 500 milligrams per day, which is taken with meals, but it may be increased in dose of 500 milligrams, which can be done weekly as tolerated, and up to a maximum of 2,000 milligrams per day. Other non-insulin medications used in treatment of type 2 diabetes mellitus in adults include the GLP-1 receptor agonists, the DPP-4 inhibitors, the sulfonylureas, which meglitide, thiazolidones, and SGL2 inhibitors. So glucose monitoring is key, just like the same way we do for type 1 diabetes mellitus. And all it does is to assess response to therapy, but the individualization of the frequency of monitoring is important. So individuals with good metabolic control, which one is able to manage with lifestyle and or metformin alone, do not require frequent routine monitoring, other than when changes in therapy occur or during intercurrent illness. Those using medications that cause hypoglycemia, such as insulin or insulin secretagogues, needs more frequent monitoring. If the prandial and basal insulin are required, monitoring needs to be increased, and practice used for type 1 diabetes mellitus can be applied. So another way is through surgical method, and we call it bariatric surgery. A NY gastric bypass and sleeve gastrectomy is done and improves many outcomes in adolescents with severe obesity and significant comorbidities, such as type 2 DM. And it was found that largest adolescent study reported remission of type 2 diabetes in 95% of obese adolescents at 3 years. Participants lose 27% of body weight, 13% needed further intra-abdominal procedures, 57% had micronutrients and other vitamin deficiencies. So the procedure itself may be good, but it comes with associated issues like micronutrient deficiency, vitamin deficiencies. So the therapeutic goals, ISPAD recommends a goal of HbA1c of less than 6.5% for youth with type 2 diabetes mellitus, while the American Diabetic Association recommends 7.5%. But both recommendations are consensus-based, based on maybe studies that have been done. So the target is, depending on what one will use, if you want to use other, one will use the target goal as less than 7.5%. And if one wants to follow ISPAD recommendation, the goal for HbA1c will be less than 6.5%. Okay, the acute complications of type 2 diabetes mellitus, they can have hyperglycemic hyperosmolar state and may have diabetic ketoacidosis. So those with type 2 diabetes mellitus are at lower risk of serious hyperglycemic events than those with type 1 diabetes mellitus. So both HHS and DKA occur in youth with type 2 diabetes mellitus. 5 to 25% of those with new onset type 2 diabetes mellitus present in present in ketoacidosis, while DKA in type 2 diabetes mellitus is defined and treated as in type 1 diabetes mellitus. The criteria for diagnosing hyperglycemic hyperosmolar state include plasma glucose concentration greater than 600 milligram per dl, the venous pH is greater than 7.25, the serum bicarbonate is greater than 15 milliequivalent per liter. There is absence of ketonemia, and effective osmolarity is greater than 300 milliosmol per kilogram, and may have altered sensorium, which may present in form of obtudation, combativeness, or seizures. The cardinal features are severe volume depletion and electrolyte loss. So presenting features tend to be less dramatic, as seen like that in DKA, but may still present with increasing polyuria, polydipsia, but may be more subtle. But HHS is potentially life-threatening with significant morbidity due to thromboembolic events. They may have rhabdomyolysis and a malignant hyperthermia-like syndrome. Cerebral edema appears to be rare compared to how it's found in type 1 diabetes mellitus. The therapy is restoring volume depletion, then slow correction over 48 hours. Insulin is started later than in DKA when the fall in glucose due to rehydration slows, and in lower doses, say 0.025 to 0.05 units per kg per hour. So replacement of potassium and phosphate too is also important. So like I said, if DKA is found, it's just like the way we manage in type 1 diabetes and mellitus. So for the chronic complications, it may be microvascular or macrovascular. The microvascular, there's an affectation of the nephrons leading to nephropathy, which is seen in 18 to 72% within 10 years. And rates are higher than what is seen in type 1 diabetes mellitus. And is diagnosed with taking 3 samples for microalbuminuria. A PCR may be done in spot urine, and treatment is often with angiotensin converting enzyme inhibitors, and is recommended that this should be done annually. While it may present with retinopathy, which is mild non-proliferative, and is seen in 14% of patients at 5 years, and in 42% of patients at 7 years. So to pick this, we need to do annual screening, and that is done by pupillary dilatation or using fundal photograph. One can send the type 2 diabetic mellitus patients for retinopathy once the disease has reached up to like 5 years, because it can be picked there in 14% of them, and once it's getting to like 7 years, it can be picked in 42% of them. So a need for a collaboration between the endocrinologist and ophthalmology is key in picking this. While the other thing is affectation of the neurons, which may present with neuropathy. Though it's very rare, but such study found signs of neuropathy at mean age of 21.7 years after 7.6 years of diabetes. So the onus is on one to check, do a neurologic examination once they come. We want to assess for sensation, light and deep. We want to check for You want to check for the sensation. You want to check for some other neurologic signs in them. So it's not something that will be done routinely, but at least one can endeavor to assess that. Maybe if it's just maybe once or 6 monthly, or once, 2 times a year, or once a year in patients with type 2 diabetes mellitus. While for the macrovascular complications, that's the chronic form, that's the macrovascular, it may present with hypertension. And once the blood pressure is greater than 90 centile, and then both lifestyle changes, the angiotensin converting enzyme inhibitors are recommended if blood pressure is greater than 90 centile, and both lifestyle changes, and ACE inhibitor if one will administer ACE inhibitor if the blood pressure is greater than 90th percentile. But if it's greater than 95th centile, we need to administer ACE inhibitor and lifestyle modifications, which include diet and exercise. If dyslipidemia is found, it can present as dyslipidemia. Insulin sensitivity is associated with increased triglyceride and decreased HDL. So the lipid goals is we want to achieve LDL less than 2.6 millimole, HDL greater than 0.9 millimole, and triglycerides less than 1.7 millimole. So diet is first line of treatment, and statin added only if the LDL remain above 3.4 millimole. So this further buttresses the fact that key to managing type 2 diabetes mellitus is still dietary modification. In cases where non-alcoholic fatty liver disease are seen, 25% of patients present with it, and one would need to measure the alkaline transferase enzyme annually. Other chronic complications are polycystic ovarian disease, which is seen in 12 to 23% of patients. They may present with menstrual irregularities, acne, amenorrhea, hirsutism. Treatment is lifestyle modification and weight loss. Metformin improves menstrual irregularities and hyperandrogenism. Other chronic complications are sleep apnea, which is seen in 6% of patients. How do we want to pick this? You take history of snoring. We want to history of snoring during daytime sleepiness and apnea, because if one snores, the person may not be able to sleep well at night, and the person tends to sleep more during the day. And besides, apart from that, if a child snores, some of them may develop apnea. One need to inquire that this child, while sleeping, does the child suddenly wake up and start gasping for air? All this needs to be asked while taking history. And a key thing that one cannot leave untouched is depression often comes as a chronic complication of type 2 diabetes mellitus, and is seen with 15 to 20% of patients. So the only way we can pick it is maybe while clacking, we want to inquire about the mood. We need to assess the mood. We need to inquire about how happy the child is with the illness. Is there an affectation of school activities or other forms of child's life that are being suffered? So we should always bear it in mind too that they may present with the depression. This is just an highlight of what had been said earlier, that if retinopathy is peaked, the prevalence is peaked at 14% at 5 years, may be seen at 42% at 7 years, and screening should be done annually by dilated pupil exam or fundoscopy. Nephropathy is by checking for microalbuminemia, which one may peak in 18 to 72% of them within 10 years. So there's annual diagnosis by mentioning the urinary albumin creatinine ratio in sports urine. Hypertension is seen in 10 to 65% of them, and routine clinic blood pressure measurements using appropriately sized cuff should be done. While PCOS may be seen in 12 to 23% of them, so history and physical exam is germane. Dyslipidemia too is another thing that could be peaked in 40 to 44% of them. So lipid profile once diabetes is stabilized after diagnosis. Non-alcoholic fatty liver disease too is another entity that may be peaked in 25 to 50% of them. So to pick this, we need to check the ALT annually. Sleep apnea is seen in 6%. Inquire about snoring, daytime sleepiness, apnea. depression or depressed mood seen in 15 to 20% of them. Then preventive intervention. The US Preventive Service Task Force recommends screening of 6 years and older children for obesity, and obese children offered dietary, physical activity, and behavioral therapy, because this tends to be more of encompasses the primary and secondary preventive measures, such that if they are screened, if one offers dietary advice, physical activity, behavioral therapy, tend to prevent it. But routine screening can help in early diagnosis and prompt treatment. So drugs like sibutramine, orlistat, and metformin have been used for treating pediatric obesity, but side effects limit their use. The prognosis: metabolic control is often good in the first 2 years after diagnosis, but frequently deteriorates rapidly. So long-term follow-up of patients is concerning. An Australian study of those diagnosed between 15 and 30 years of age showed that 11% had died at a mean age of 40, with cardiovascular causes of death being most common. So once the diagnosis is made, all those complications are highlighted, and the time for routine screening should be borne in mind. Most importantly, checking the blood pressure, checking for dyslipidemia will help a longer way in limiting sequelae, such as death-related complications that will arise from type 2 diabetes and mellitus. Thank you for listening, and I'm so sorry I couldn't share my slide.
Dr. Ova, I tried my level best to coordinate with your speed, and
Sir?
I tried my level best to coordinate with your speed. Uh,
Oh,
so now